Good evening, everyone. Thank you for joining us tonight for the second webinar in our series about transplants. So tonight's transplant is all about side effects and how to manage them. And we're going to have a good discussion about the different types of side effects that you can experience during a stem cell transplant and when those side effects can occur, and also a bit more about how to manage them and what support is available at all of those different stages. So I'll start by introducing myself. So some of you might know me. I'm the advocacy officer at Leukaemia Care, but I'm also, before I joined Leukaemia Care, I was also a patient. I had ALL a few years ago now, and I had a transplant myself. So I know all about these side effects because I've been there, sat in that hospital bed. So yeah, I'm really looking forward to this today. And I have got two amazing guests with me today. So Ruth and Lisa, if you could introduce yourselves.
Hi, thank you so much for asking us to speak today. So my name is Ruth Clout, work at the Christie Hospital, Manchester. I've been working in haematology and transplant for, we're just working out, about 22 years now. I've been at the Christie for 16, and I'm currently working as the lead nurse for our inpatient unit, so our haematology and transplant and TYA unit.
Hi everybody, my name's Lisa Jeffrey. I also work with Ruth here at the Christie, and my role within the team is actually the transplant clinical nurse specialist. And again, in haematology, I've been working for about 17 years, specifically in this role as the transplant clinical nurse specialist now about 7.5 years. So we both very much enjoy these topics. So again, thank you for inviting us.
Oh, that's amazing. Thank you both for coming. I just want to do a little bit of housekeeping before we start. So the way that tonight's going to run is we're going to have a bit of a talk and an overview from Ruth and Lisa, and then we're going to move into a bit of a discussion. I've got a few pre-prepared questions all about transplant and side effects. But of course, if you're watching on Zoom, then please do put your questions in the chat. And if you're on Facebook, then pop them in the comments, and then we've got someone in the team who is feeding them back to me. So hopefully we'll get around to asking them. So I think that's everything from me for now. So over to you both.
Okay, I'll just share the screen, see if I can do it slickly now.
Yeah, we've got it.
Got it?
Just put it on a, that's it.
Yeah. Okay. Okay, so we're going to talk to you today about what can help you manage your side effects during the stem cell transplant. So as I say, I'm Ruth Clout, and I've got Lisa Jeffrey with me here as well. So we're just going to sort of take it in turns to talk through the slides, and then, as Sophie said, if there's any, any questions or anything, either pop them in the chat, and we can hopefully have some good sort of discussion afterwards. So the objectives of this webinar is really to hopefully for you to gain an understanding of potential treatment related side effects, give you advice and tips on what to prepare for, think about sort of what causes the side effects and how we can treat those side effects, a little bit about sort of communication management and coping strategies of what support is available throughout the process.
We're just going to talk about, there'll be different areas of obviously the transplant process that we'll be talking about. There's obviously when you first come in, after sort of identifying your admission date, you then have your first part of your transplant, which would then occur when you first come in, which is obviously the conditioning chemotherapy. Everybody's, as we call it, workup regime, so that will obviously account for a couple of different chemotherapies and obviously immunotherapy. And then you go on to obviously have your cell infusion, and then we'll be talking about a period afterwards where it's patient monitoring, and that's kind of the stage where we're waiting for that donor cells and those that engraftment to happen, for those blood counts to recover, and obviously looking out for any signs of potential side effects.
Some of the possible side effects I'm just going to talk through now, and as Lisa said, they will be, the side effects can be very much related depending on what stage of your transplant you're at. So some of the ones which are on here will be kind of like that immediate phase after you've had your cell infusion or while you're having your chemotherapy conditioning. So things like nausea and vomiting, and for those of you that have had chemotherapy before, I'm sure you're well used to taking the anti-sickness prior to your chemotherapy. And certainly now the anti-sickness, the antiemetics that we give patients are a lot better than what they were a long time ago. So it is something that we can keep under control. It is important that, you know, when you're in, you do take your anti-sickness medication as it's prescribed, because the reason you're not feeling sick is probably because you're having your anti-sickness. So, you know, if there are times when you are feeling nauseous or vomit outside of taking the antiemetics, important to let your nurse and medical team to really, for us to intervene and try and look at what is best to see if we can get you some alternatives. Within alongside the sort of nausea and vomiting, there can be taste changes, which again might not be an uncommon side effect for those of you that have received treatment before. And those taste changes, we often hear that patients might say, I just really gone off tea, or there's, you know, water can just taste absolutely horrible. And there are certain things that you might just really like and that taste better, and certain things that you've always loved and just suddenly can't bear the thought of even going near. So these are all things which are kind of quite useful, not quite useful, they're quite unuseful, but they're quite, we do see them a lot within our patient group. And I think, you know, it is just trying to find out what is the best thing for you to eat, and to find, you know, what you like and what you don't like during that period. And your taste will, you know, hopefully come back afterwards, and you know, you will find that you hopefully do like tea again. Not always the case. Some patients do say that it actually puts them off certain foods and things afterwards, but certainly it's, you know, usually a short-term side effects. Reduced appetite is again something that we do see within this period, and this is very sort of up and down. It might be while the patient's having their chemotherapy at the inpatient time, it might be after they've had their cells and they've got other sort of side effects which are then causing them not wanting to eat. And we, you know, the advice really that we want to give for those and within the altered taste is try eating sort of little and often, snacking, have what you fancy rather than really, you know, just forcing food down, you know, yourself. It's really important just to eat what appeals to you, rather than thinking that, oh, I need to eat that because it's healthy. Some, you know, flavors and foods and stronger flavors, you know, cold foods, experiment with different things to try and mix it up a little bit and just see, you know, what works for you and not. And then the other thing that we would do is, you know, within our organisation, every patient that comes through for stem cell transplant would be referred to a dietitian. So, you know, we really try and work with the patients and the dietitians to try and establish some sort of common areas of interest in food that really work with patients and what appeals to them. One of the other side effects that can occur sort of in this early phase following transplant and following chemotherapy is a sore mouth. So this can add to the difficulties of sort of altered taste and reduced appetite. And a lot of these do go hand in hand. We would encourage, you know, patients to really try and keep their mouth clean, use saline mouthwashes, a soft toothbrush. Depending on where you have your transplant or which organisation, they would have their own protocol for mouth care. So be advised by sort of medical and nursing team and pharmacy team of what you would need to use. But certainly saline mouthwash is probably one of the best things in just trying to keep your mouth, you know, salt water, keep your mouth clean. And as I say, soft toothbrush. We would, for all of those side effects, which are sort of group there at the top, we would work together with the medical team, pharmacy team, dietitians, and then also we do have, we're very lucky here that when we have access to our complementary therapy team, which are really good at sort of supporting our patients through various different side effects throughout their transplant, you know, process. So just moving to the bottom there, you've got on here GI disturbances, so gut disturbances, and this can come in the form of either constipation or diarrhea. Some of the chemotherapy and antiemetics, anti-sickness can cause constipation, but then further down the line it might be that the chemotherapy has triggered off sort of that irritation of the lining of the stomach. And certainly when patients get that mucositis, the sore mouth, what you see in the mouth, it can all be irritated all down to the gut and then sometimes cause diarrhea as well. So this obviously then links into reduced appetite. There can be some weight loss, and this is where we obviously rely very much on our dietitians and that expertise and working with the team of what is best to be eaten and what supplements we can advise for you to take, particularly if you're having diarrhea. We do advise obviously drinking plenty of water to try and really prevent that dehydration, and good mouth care is what I've obviously already said about.
So obviously, as Ruth has kind of spoken about there, you tend to find the whole transplant process is extremely individual, even in comparison to what you might have experienced with your chemotherapy. There's things that will sort of follow you through, so things that you've experienced, and then there'll be, you know, new complications. So you may experience some of the, you may not. One of the other side effects is obviously infective complications. So very much like what you would have had with your chemotherapy, whilst your donor graft is waiting to establish itself and then develop good blood counts, you can find, regardless of how much preventative measures you put in place, it is sometimes always possible to get an infection. And obviously, as you know, with lowered counts, you would be more at risk of that. What we tend to then do is, particularly here, as Ruth said, each centre will have its own protocols as to how it manages infective complications. We would obviously be doing regular, how we'd manage it here would be regular assessment and observations. Obviously then clinical investigations, so we would do lots of blood tests and possible cultures to try and isolate a source of infection. As a patient, to help manage these situations, it's just really about letting us know about sort of early sort of experiences of it. So if you do start to feel that you're feeling particularly hot, or you do notice any particular rashes, that type of thing, anything new in yourself, you know, your medical team will always be in there, but even the nursing team as well, they'll be seeing you, checking you regularly, and it's just about letting us know so that we can make those early interventions, do those blood tests and isolate any sort of source of infections. Again, you know, we'd be very much relying on the medical and nursing team to sort of identify those and do the relevant tests. And it may include as well, you know, to manage these side effects, some additional diagnostic services. Sometimes it may be that we need to, you know, do some additional tests like scans and x-rays and things, just again to sort of identify any potential side effects. Some other side effects you may experience throughout your transplant could possibly be skin rashes. Your skin will be particularly sensitive. Again, as we've said, that will be down to your conditioning therapies. As before, you'll find that it might feel particularly dry or very sensitive. And we would tend to sort of, you know, recommend keeping a really sort of moisturized skin, sometimes non-perfumed, just because sometimes you can find sort of highly perfumed deodorants, that type of thing can irritate it. Also, there's the other side that skin rashes can also be a source of infection, but they can also be down to the conditioning therapies as well. Sometimes, as I'm sure you're all aware, that all the drugs and therapies we use come with potential side effects. And again, you know, it could be a possible sort of allergic reaction and things. But again, throughout this whole process, it will be about sort of that early detection, identifying what the side effects are, and then obviously with the medical and nursing team putting a management plan in place. We've put here, particularly because during the first early phases of transplant, you tend to find, particularly with acute graft versus host disease. And obviously, you know, graft versus host disease is quite a main side effect of transplantation as a whole. It very much is based on how your graft interacts with your own immunity, and it can come in various different forms. A lot of the time in the acute phase, it would tend to be sort of skin rashes or skin changes. And also it can, as Ruth went back to before, it can also come in the side effects of sort of gut disturbances, and also sometimes it can just sort of affect your blood count slightly, which we, you know, your medical team and nursing team will be looking after those. So in terms of managing that, again, you know, we those three things, we'd have to just identify what the side effect presented as, identify what it was, and then obviously put in those different regimes to try and help it. With the acute phase, as we said, we're very much sort of centered around, you know, that clinical observation. You know, a lot of monitoring goes through without the transplant process. So I don't, you know, when we say, you know, make sure you report it to us, I don't think patients get much opportunity not to report it, because we tend not to leave you alone very often. So you'll tend to find that, you know, everybody will be taking a very close eye on what side effects are presented.
So all of these sort of side effects that we're talking about, as I said, they very much sort of feed into the next one. And after we've just listed all those ones to you now, I think you're probably feeling quite fatigued and lethargic just hearing us talk about them. But actually, that is something which we can't really, you know, it's very hard to explain that feeling of lethargy and fatigue. And it's something that you know, you may or may not have experienced already, but it's very hard to sort of really say, you know, I'm tired. But actually, you know, when you feel so exhausted that your levels of energy have really kind of just gone down. So, you know, while you're in hospital and you're in the same room and you're in isolation, that can have an impact, because actually your normal exercise that you do, your daily life, your fresh air, you're getting out, having a walk around and things, that isn't there while you're in your side room in hospital. So we do refer to, we have a physiotherapy team here. We try and set sort of just some sort of sensible plans of like exercise plan, you know, little and often, set goals each day. We've had patients which have like walked around the room on a daily basis at various points just to get their steps up and to try and combat some of that, you know, those feelings of fatigue. And then really, you know, the psychological impact, again, that's very hard to explain how that might impact you and how that will, you know, affect you as an individual. And you know, as a team here throughout the whole point from your diagnosis all through your transplant journey and everything, we do as a team really try to support patients through that sort of the psychological impact of you know, a cancer diagnosis and transplantation, because actually how you feel in that time frame will vary. And on one day you might think, I can take on the world, this is amazing, you know, I feel great, and on the next day you know, you don't. So it is really important to have those conversations with us about that. We can ensure that we're referring to the correct services and getting the right support in for you. So whether that's sort of a counselling team, or we have a psych oncology team here, whether we refer you to complementary therapies, there are also sort of various charities, as you know, because you're obviously tuned into this Leukemia Care webinar today. And so there are really good resources out there for patients to help support in this, you know, difficult time. And then the other thing really is obviously the altered body image. And this kind of almost links in from what Lisa was saying about sort of things like, you know, the acute graft versus host disease, and the treatment for that would be steroids. Sometimes patients can kind of get a little bit, you know, bloated and things after steroids. That then has an impact afterwards. And I can see Sophie nodding her head there. So I think you should probably be able to add to this afterwards. And this is obviously all part of a you know, important management plan. But again, you know, have they speak to someone about how you're feeling, because that actually is quite normal for patients to feel like that. And actually that's where you get the support from other patients, isn't it, as well? And you know, that's, I think, having those sort of like buddy systems in place for patients, because actually as professionals we can talk to you about how to manage the side effects, but we don't really know how it feels to have that altered body image and to know that psychological impact of having a transplant. So do utilize those really excellent, you know, patient advocacy networks and support systems out there. And then the other thing we just added on there is document how you feel. It's very, you know, some people like to sort of write a diary. The time that you're in hospital, you know, depending on how long you're in for, can go very, very quickly. So if there are things that, you know, you just think you can make a note of how you feel on the day, what's good, what's bad. And then actually afterwards, as you're sort of, you know, just trying to process everything that's happened, it's quite good to be able to go back to that and read through, because there's a lot that you will remember, there's a lot you won't remember. But I, you know, personally, I think sort of, you know, making notes on how you're feeling is a good way of dealing with that sort of psychological impact afterwards.
We just wanted to kind of, obviously transplant is quite a complex process, but we kind of just wanted to think about, you know, as a patient, what it is, you know, trying to get some sort of, you know, a small amount of advocacy and control over the situation. So we kind of thought, you know, definitely pre-transplant, I think it's really good to try and put a plan as much as in place as you can in terms of coming in. And obviously, as we all know, try and keep as well as possible pre-admission. If it is that, you know, that whilst you're waiting for that admission, you develop sort of any new symptoms, anything like that, it's always really good to let your transplant team know. And also to report any new symptoms and write them down. As Ruth said about telling us about your previous experience, it's really key, because if there are certain antiemetic drugs, certain experiences you've had with your chemotherapy that worked for you or didn't work for you, or you had that experience, you know you better than we ever can. So that is really, really good and really, really sort of vital for us to know, okay, so we know this worked really well in the past and we can try that again. You tend to find with the transplant process is that it's so individual that it literally is a lot of the time at that beginning phase, if you do get any sort of acute side effects, it's about trial and error sometimes. As Ruth said, there's such a wide range now of treatments and therapies we can use to manage things, that just because maybe one anti-sickness hasn't worked, that doesn't mean that that's all we have. It's about us finding the right combination for you. And sometimes that does take a little bit of trial and error. So as Ruth said, you know, also into your recovery after transplant in terms of side effects, there are days in your recovery, particularly those days where you do feel particularly fatigued and lethargic, that it kind of sometimes feels that you're not making much progress because it's quite a slow one at the beginning. So sometimes having that journal or that documentation can actually make you look back the week before and think, oh, actually,
Come a long way.
I have made, you know, I have managed to go for that walk down the road, and compared to how I was feeling, you know, 2 weeks ago whilst I was in, you know, that can really help just to give you sort of that encouragement, and also just to kind of, sometimes when you're going through this process day in, day out, it's very difficult to see those subtle changes. Also distraction therapy as much as you can whilst you're in. You know, sometimes there'll be a lot of patients, you know, feedback to us that the isolation phase and coming in for that period of time actually goes a lot quicker than they kind of expected, you know. But there are times, you know, where just to have that distraction from sort of the clinical area, you know, I always say, you know, anything, if it's music, you know, if it's series, lots of people bring in lots of books, but sometimes don't feel they have the concentration for it because it takes quite a lot, you know, they find they're reading the same page for several days. So it's always good to sometimes just have more of an audio thing as a sort of a distraction therapy. Also, you know, we can't say for your side effects, the support of your family and friends, again, they can be a really good reference point for us, you know, if you're not feeling particularly well one day, you know, they can also offer us lots of information. And sometimes, you know, it's also good in terms of managing your transplant. Sometimes I know lots of patients, particularly now, you know, we're all very contactable. They get inundated with lots of messages from everybody. And sometimes it's really worthwhile sort of almost designating a main contact. So if you're having a day where you just want to sleep, you know, that everybody around you isn't worrying that they've not heard from you, you know, and that person can then feed back. And sometimes that can just really help manage those days if you're having quite a few side effects that you just, you know, can't do that extra sort of contact. And preparation, you know, myself and Ruth can talk about what our service can provide, but, you know, talk to your transplant coordinators, ask them what you can bring in. You know, if you are able to visit your unit now, you know, if it is allowed. Obviously with COVID there's different restrictions in different places, but it's quite good to prepare. And also what you can bring with you. We have a although we have a kitchen on the ward, in the sense, you know, if there's certain foods, certain squashes, cereals, anything that you think you can fancy but obviously isn't on the hospital menu, if you're able to bring it in, then again that can really help manage some of those side effects when you know might not fancy anything on the menu, but you would actually, you know, fancy a favorite packet of, you know, biscuits or something like that. Then again, just to prepare for what you can bring with you as well.
And then we just sort of take you to the useful resources which are within leukemia care. So they are, we've spoken very much generally about the allogeneic stem cell transplants today. So having a today, so obviously having a donor transplant, but there are, if patients have their own stem cells, there are obviously the resources there for the autologous stem cell transplant as well. And these are on obviously the leukemia web care website. So that's our sort of little presentation over and done with now. But if you're over and done with, that sounds really bad. I don't mean it like that. But if there's anything else anyone wants to ask us, then feel free. I'll just stop sharing now.
Oh, thank you both. That was really good. No, honestly, I think that you've really summed it up quite well there. A lot of what you were saying, I was thinking, yes, this is bringing back a lot of memories. And it is, I think it all comes down to that sort of, you know, it's very, very individual. Like transplant is different for everyone. You won't speak to any two patients and have the same experience ever. And even though there are all, you know, there are things that we can all sort of, you know, relate to each other on, no single experience is the same. And I think that's important for anyone who's got transplant coming up. You know, you might hear some things that will make you a little bit worried, but it's not always the case.
I think that, you know, there is naturally a lot of anxiety about coming in for a transplant, particularly because there's such a whole host of potential complications. And I think we always, you know, what we need to stress is the word potential. You know, they are potential, but it doesn't necessarily mean you'll experience those. You can have, you know, patients who have a very similar treatment pathway, but their delivery of their cells and their recovery will be completely different. And some people, you know, it's like anything, it doesn't necessarily mean you'll experience all those side effects. You know, there may be some that are more predominant for others. And it's just about, as we said, just early detection and management.
And I think just, you know, when I'm sort of going through patients about how they're likely to feel during their transplant and, you know, on the ward, etc. And one of the things that I kind of always say is that, you know, we will tell you what is expected and what is normal. So if you're in a hospital and you're feeling worried that, oh my God, I've got this, we will explain that, you know, this is normal, this is what we're going to do for it, this is how we're going to help you with this, and try and sort of support you in that through that time, because obviously, you know, like we've all said today, nobody is the same and everyone does experience, you know, different things, but it's kind of we need to do the worrying for you, and we want to be able to take away and relieve some of those you know, concerns that you have with any of the potential complications. And you know, you might come in and you're almost, if you're bored, I think being bored's quite a good sign, because you're feeling, if you're well enough to feel bored, then that's great. So if you're feeling bored, don't be too embrace the boredom.
Yeah, definitely. I think that no, it's definitely like that. And it's like what you were saying about like the anti-sickness and things like that. Like, you know, if one thing doesn't work, it's okay. Like there are other things that you have. I think I did get through about 5 or 6 different drugs myself. Like it you just have to find what works for you.
It is, a lot of it is that combination. And also the delivery, you know, you will tend to find, you know, if I take this, you know, you have your anti-sickness, allow it to work, and then maybe try some breakfast. So a lot of it is just about working out what regime works best for you, you know, in terms of eating, side effects, and managing them. And you do tend to find that you get into a pattern of kind of how to do it.
Just work with your clinical team, you know, tell the ward staff, tell your nursing team, tell your HCAs, medical team exactly what you experience on that day, and then they'll be able to sort of, you know, don't hold back, because we don't, you know, we'd rather people be completely open about how they're feeling and any symptoms they're experiencing, because then we can actually get the right sort of treatment and options and, you know, support for you within that time.
Yeah, definitely. I think that you know, it's just hard as a patient sometimes. I think I always remember when I was having my first radiotherapy, full body radiotherapy, and I remember thinking, I do feel a bit sick, and I thought, no, it's just in my head. And I remember speaking to the radiographer, and I said, like, how quickly can nausea set in? And she said, oh, it can be straight away. And I was like, oh, okay. And I think within about 20 minutes I was gone. But
And I think for patients as well, I think they always, it's always that worry that when you're in isolation, you're kind of like, oh, well, if I buzz, I've got to buzz. But buzz for sort of anything I need. And patients get quite worried, like, oh, I've only just buzzed. But that's the nature. Yeah, that's what it's there for. That's the nature of the setup. We all work that way, and that's what we'd expect. What we don't want you to do is, to be, absolutely. It's just about, keep buzzing, keep letting us know, and we'll get to the bottom of it. I think that's the key, really.
Yeah, and I think that's an important thing as well, like just being so open with your team. And there are so many times where I think even the look on your face sometimes can tell the team what they need to know, and that's why it's so important that you keep seeing each other and coming into that room. And like I say, isolation, it can be quite lonely, and we're seeing the nurses, it does cheer you up. And I think if you can put on a smile when you can, then they always knew there was something wrong with me if I wasn't smiling. They always said there's something not right because you're not your usual self. And you really get to know your team, and your team know you. And it's so important to have that good relationship and to keep that going throughout the process, because you are in for a significant amount of time. And like you say, it's a good sign if you're feeling a bit bored, because it shows that you're feeling a little bit,
Also, it's really worthwhile mentioning that, you'll see your regular team that come and review you every day, but there is such a wider team behind the background. There'll be a lot more discussions sort of in the multidisciplinary team meetings, so that if it is that, you're experiencing side effects, that will be discussed quite widely as to what we can do, so there'll be lots of different people thinking up solutions to try and manage things if you ever are struggling. But as you said, throughout your whole sort of pathway to get to transplant, you often know your clinical team very well. They often know you very well. And so, as you said, even if you're not feeling like you can report these things because either you're just feeling too tired, or you don't want to, the clinical team will quite easily pick up on that change. Definitely.
100%. I'm just looking in the chat. We've had a question about GVHD. Now, we spoke a lot about that, and I know that is something that as a patient you're told a lot about when you're going into transplant. So someone has asked, if you suffer from GVHD, does that mean automatically that the transplant has failed, or can you still have a positive outcome after having GVHD?
So graft-versus-host disease, obviously post-transplant, it's one of the main complications. Such what that actually means is that the donor graft is quite strong, and what we're looking for with transplant is getting everything on a nice even balance. So we have to control your immunity with all the conditioning to accept the graft. When the graft is getting quite strong, what it can then do is sort of recognize some of your own cells as sort of unusual, and you get this inflammation response. So it's actually an indication that the graft is quite strong. So some people would say there's, an element of it that's a good sign, but what we don't want to do is allow that graft to get too strong too soon, because that can obviously cause complications. In terms of long-term outcome, it's something that would very much have to monitor, but it's very much also got management treatments in place. So that, as Ruth said, their first line would be steroids to do sort of to see what that acute response was. What we'd be aiming for is to almost use immune suppression, use steroids and other therapies to then control your graft, just to a point where yourself and your graft sort of learn to live together harmoniously. And I always kind of say, with any type of transplant, it's about you and your new donor graft learning to live together.
Mm.
And a lot of the time that takes time. So it's in that sort of first phase of recovery when there's sometimes a little bit of a battle that the graft versus host disease can happen, but it wouldn't necessarily, you know, it wouldn't be the main factor of the outcome long term.
That's great.
Does that
Thank
answer the
you.
question?
Yeah, that sounds good to me. No, but it is a fine, like you say, it's a fine balance, and it's when the graft is quite strong, it's it's a bit difficult, but yeah, there are
housemate.
Yeah.
yeah,
Yeah.
you know,
You've got to work each other out, and then you can live harmoniously together, and that's kind of what we're aiming to do.
Yeah,
but it's
yeah,
just that
definitely.
initial phase that can sometimes be a little bit, you know, bumpy when they first meet.
Oh yeah, definitely. I always found it strange, like with my transplant, my donor was, I think he was O negative, and my blood group changed for like a day and then went back to AB negative. I was just like, oh, okay. So
that's it.
It was
lots of changes.
Yeah, definitely. But speaking about blood as well, something that I've got on my list of FAQs is, obviously we know that with the conditioning, the aim of that is to sort of, you know, dampen everything down and to make room for those new cells. So in those early stages, is it quite common that people will need a lot of supportive blood transfusions and things like that?
Yeah, so you know, we spoke about sort of blood counts and things, and one of the things after the conditioning chemotherapy would be to monitor the blood counts on a daily basis. So we're looking at the white blood cells to see that whether you become neutropenic, which is, you know, we would expect, and then we'd also be looking at your platelets, which help make your blood clot, and also your hemoglobin, which is what carries your oxygen around your body. So again, for those of you that have had, you know, treatment for you know, blood cancers in the past, and you may or may not have had blood and platelets already, they would have to be within a certain threshold, lower than a certain threshold, for us to be able to give you blood or platelets afterwards. But it's certainly something that we see for a period in that sort of short-term effect until sort of the graft really does take hold and the counts sort of recover nicely. It might be that once you're discharged from hospital, you need to continue to have blood and platelet support in the day unit facility afterwards. But again, we would follow up with patients afterwards, looking at their bloods and assessing that accordingly, and giving blood and platelet transfusions when necessary.
Yeah, definitely. I remember having a few whilst I was in, and also quite a few platelets. My platelets were not having fun in there. Many nosebleeds.
Yeah. So I was just going to say, I mean, this one of the signs and symptoms of, you know, obviously platelets is the bleeding. So typically it can be in nosebleeds. We would be looking at patient's skin to see if there's any new signs of bruising, any bleeding, asking questions like that. So there's quite a lot of intrusive questions that we ask on a daily basis. So it, you know, it can be around sort of whether you're bleeding, it can be whether have you had your bowels opened, are they loose, are they formed? So, you know, all these sort of things which you might just think in a normal setting, why the heck are they asking me all these things? There are, you know, hopefully within the sort of context of the presentation we've given today, you can see a bit of a reason as to why we ask those questions.
Yeah, definitely. It's all to help you as the patient, and, you know, you want to make sure that we're okay, and we want to feel better, so we've all got to work to make that happen. But no, definitely. And it's, you know, you go through that routine of answering those questions, and, you know, when you're tired, you can get a bit annoyed, but you know, it's all just
been asked that already.
Yeah, like it's all just, you know, it's all part of it. You just go through the motions, and you know, you get there. But I always used to sort of say, like, you know, always celebrating like the little wins, like throughout transplant, because it can be a really hard time, and and it, like you say, it's quite isolating and things like that. So, you know, if you can, you know, have a little bit of a bite of food when you've not felt up to it, or, you know, you can drink you know, your jug of water and things like that. Like to me, that was always a win. And that was like what helped like me and like my family through it as well. And I saw like someone in the chat, like I know we mentioned earlier about getting one person to sort of tell everyone else what's going on, and someone in the chat has mentioned like videos to send out to people. And I think that's such a clever way to do things, because I know that some of my friends who went through transplant also did that for their family too. But it's just finding what works for you, and like, you know, if you feel up to doing that, then that's amazing, because not only are you updating everyone else on what's going on, but you can also look back on that after and just think, God, like look where I was and look where I am now. Like it is, it's, you know, I know it's a bit of a cliche to say it's a journey, but it is. And you don't realise until you're out of it on the other side, even if it's only a few weeks after, how far you've come.
Yeah, and that's what I mean. It is those small wins, and sometimes that's why writing things down, or just even trying to get a snapshot one day of how you're feeling. A couple of weeks down the line, you'll actually think, okay, actually I have made progress. But like you said, sometimes they're so small, you can't necessarily see it straight away.
Yeah, definitely. And I know we spoke a bit about peer support as well, and I feel like that's something that's so underrated. I didn't realise how amazing it would be to, you know, be part of such a massive community online with people who are going through exactly the same thing. And you know, it normalizes it, essentially, what you're going through. And you know, you've got other people to bounce off and say, like, you know, did this happen to you? And it's like, oh yeah, like that's, you know, that's fine, that's normal. It's like,
So it's I think the transplant process as a whole is quite a difficult thing to explain to somebody. You know, so sometimes, like you said, those peer support of people who have experienced it does give you that different sort of opinion or support, because it's quite hard to describe to people what your experience has been. You know, a lot of people sort of, you know, even with, they kind of think you're coming in for more chemotherapy, you know, can't see that long-term recovery that you have to go through, and it's quite difficult sometimes. So absolutely, peer support is always a good thing.
We, the transplant team, have always tried to put patients in touch with, you know, offered it if they want to speak to another patient. So within our centre, we do sort of try and do that, don't we? And you know, just as an internal.
Yeah, definitely. It is really important, and it just helps, like, you know, just being able to bounce it off of someone else. And it makes you feel less alone in it all, because, you know, when you're in that room and you're on your own, it can feel that way, but it definitely isn't the case. And it can also help with, like, you know, talking about food and things like that. So, like, you know, asking someone else, or, you know, what did you find was helpful for you? Like, I always found that I was always eating ice and ice cream, and that helped me. I was living life with that.
Yeah, absolutely.
Calories, just get the calories into you.
Yeah, definitely. And you know, when I think one day, like quite a bit into my recovery, I think I said to my dad, oh, actually I quite fancy some chicken nuggets from McDonald's. I think he nearly dived out of his chair to go to the drive-thru. Because it's, you know, when you don't want anything for so long, and then you suddenly do, it's like, oh, like,
exciting. Oh, she wants something different to eat. I know.
But,
and this is it. You do tend to find as a patient, you know, lots of my patients have sort of just honed into one thing that they fancy to eat, and that's it. And they're kind of, you know, when we just say, if that's all you fancy, just absolutely eat it, 100%. You know, as I said, until your taste buds return, which can take a couple of weeks, and a lot of the time, you know, it's not even necessarily that you'll get a sore mouth, but sometimes you just can't taste the food. So it's just kind of becomes a little bit of a chore, because it doesn't taste of anything. So it is, you know, as we said, like about experimenting with flavors and things, and hot and cold foods, just purely because if you can find something that you like, then we could kind of say, you know, absolutely, it will get better and it will return. You know, you tend to find that once your cells have engrafted, then a lot of the acute side effects do tend to ease slightly.
Definitely. Keeping on the topic of food just for a minute, is there anything that you should avoid when you're having transplant?
This is my Bruce's area of expertise, food.
So the food is kind of one of those, I guess, always been a bit of a challenging area around what patients can and can't have. And there's been a lot that has been spoken about in the past, and people might have referred to clean diet or neutropenic diet. And there's been quite a lot of sort of quite significant restrictions put on patients. Now, certainly within our centre, we have really tried to relax our guidance now to make things easier. And what we're advising is to very much follow sort of the food safety approach. So ensuring that things are well cooked, prepared in a clean environment, and very much almost follow like the pregnancy diet. So things like, you know, if you can avoid sushi or clams, or it's those sorts, food where there's a risk of food poisoning. So things like, eggs, you just want to make sure they're well cooked. You make sure they've got their what's it called, the lion's stamp on it. Things like some of the sort of, avoiding getting things from delicatessens where things have been sat out for a long time. Takeaways is always a little bit of a challenging subject. So we would advise that if you are, when you're at home, your own hospital would have their own policy on that. So I don't want to advise any takeaways to anyone while they're an inpatient, because you would need to check what your hospital is advising. But certainly to sort of get it from a 5-star food hygiene rating. You don't want to go down to sort of a kebab van in the, on the edge of the city or whatever, just to get something that isn't cooked properly. So it does very much come down to how it's cooked, how it's prepared. And I think that's really sort of the best advice which I can kind of give you. But you do need to check with your hospital what their restrictions are, really, because they will be varying. We are trying to look at this actually within just the transplant community to see if there are some better guidance that we can give for patients on this. So hopefully there will be in the future, just to make things a bit easier.
Yeah, definitely. And just like you say, being mindful and making sure that you're checking with your team what they think. And yeah, definitely.
Yeah.
I'm just having a little look at a few questions that we've had in. So someone has asked, they said that they had a sibling transplant, and they were told that you would possibly need less immunosuppression if you're having a sibling transplant. Is that always the case?
Yeah. I mean, I think this is one that may need to take back to sort of their clinical team, because actually, in theory, if you've got a sibling donor, you're going to be closer matched to that sibling than, well, not in theory, you will be, compared to sort of like an anonymous donor. But the actual sort of the timings of the immunosuppression and everything would be sort of very much guided by the clinical team. So it's quite a, yes, they should be better matched because they're more, they're a sibling, so they've both got part of mum and part of dad, whereas actually an anonymous donor doesn't. So but I think if there are any questions about what immunosuppression they're having and when and why, I would speak to your medical team about that.
That's brilliant, thank you. Just having a look at another one as well. So someone has said that they had an autologous transplant. And they said, like, to help with avoiding GVHD, why isn't that a preferred option, to have your own cells back rather than having a donor?
Do you want to go? You go.
So obviously, having an autologous stem cell transplant, it will very much depend on your disease group. So there are some disease groups that can be managed by having intense chemotherapy followed by your own cells. In other areas, depending on what hematological disease you have, that isn't an option, just purely because we almost need a donor transplant to take over the function of that bone marrow rather than your own autologous cells.
Yeah, and I think with the autologous transplant, you're relying on those big doses of chemotherapy. Whereas we know for the donor transplant patients, that chemotherapy alone hasn't worked for those patients. So we need to do something else. So that's, really, I mean, that's.
So that's why we can't necessarily offer somebody their own stem cells back.
And we may have done it. We may have done an autologous and then followed on with a donor transplant afterwards. So
that's something we've done as well. So it would necessarily be about that disease group, how it was managed, and as we said, if we cannot give somebody a long-term remission from just chemotherapy alone, and their own stem cells to be returned, then we have to look for a donor who would then almost take over that bone marrow function.
And there is the UK guidance within that of so within the sort of the British bone marrow working group, there is very much the cases of sort of the risk stratification, if you like, of when patients would need a transplant, when it's recommended and when it's not. So it does very much depend on your disease type, your remission status, and your overall sort of, prognosis. So all of those factors are taken into consideration rather than just giving somebody a transplant straight away.
Yeah, so it would all be determined as to what was considered the best option for
you.
And in terms of what your underlying disease was and how you'd responded to previous treatments, and also if there was any sort of underlying reasons that would indicate that it would be better to go for an allogeneic stem cell transplant rather than an autologous.
Yeah, it all comes back to that, it's very unique, and even from that point it's all based on your situation and you as an individual. It's really hard to put a blanket term over it all. And there's so many things that go into deciding everything about a transplant.
And there are so many factors, and we know so much more about the diseases now. That really does sort of almost pave the way of what pathway you're going to go down in terms of your treatment. So by having when a patient is diagnosed with whether it's myeloma, lymphoma, leukemia, all of those kind of factors are looked into as to why a certain type of transplant would work for you and why one wouldn't. So we know a lot more about these treatment diseases and diseases now. So that
the diagnostic testing is a lot more thorough now. That gives us a wider picture as to what would be the best transplant options for you. And as we said, your clinical team and your clinician would decide what options would be the right one.
That's great, thank you. So we've had a question about a little bit further into the recovery process, so a little bit further into recovery, and in terms of blood counts. So someone has asked, what care can you expect after a transplant over the longer term when your blood counts may not have fully recovered yet? So will you still be under the care of your team, and will you still be actively looking out for things like infection and things like that?
So post-transplant, there's sort of different centres will manage it slightly different. For us, the recovery post-transplant is vital, really, in terms of, you have your cell delivery and your engraftment when you're on the ward. Obviously, you would expect to show some count recovery then. But at that stage, your immune system is brand new. It's brand new again. And, what we would then be needing to closely monitor is for potential side effects into your recovery. So such as graft versus host disease, infection, and, looking out for the side effects of your chemotherapy and conditioning. So your sort of kidney function and long-term, looking at your body and potential side effects that way. We tend to see people on a weekly, sometimes twice weekly basis as an outpatient when you first go home. As you move away from transplant, that gets less and less, but particularly here at the Christie, we're still quite possessive. We don't let you disappear anywhere soon. We're very much monitoring for long-term effects, and then we even have a late effects clinic. So anybody who's 1 year post transplant goes into that clinic, and then we look for sort of a long-term effects of transplant. And we talk a lot about a 1 year period post-recovery for allogeneic stem cell transplant. And again, that's very individual. That doesn't mean that we'll necessarily be expecting you to be unwell. It's just about us continuing to monitor for these potential things like infection until your new bone marrow has time to establish itself and build that immunity again. And that's sometimes what can take the time. But definitely, from our perspective, we have quite a close follow-up process to look out for those even once you've gone home.
Yeah, definitely. And it's all part of the process, like you say, like it's all part of that that monitoring. And I'm keen not to talk too much about the longer term, just only because I think we've got another one coming up in this series about more of the later effects. But one thing that I just wanted to touch on slightly, because it is part of this process, and it is something that you're told about as a patient when you're about to go through transplant, and that's a little bit about infertility and menopause. Is that always the case for everyone, that will happen, or is it again an individual thing?
Yeah, I mean, we would expect somebody after a transplant, the likelihood would be that they would be infertile and potentially go through an early menopause. So that is something that we would, would kind of expect to see. However, there are always rare situations, and we've had certainly, I think this is really important, that if childbearing age, female of childbearing age, and and male, but to have those discussions, because actually we have had some of our a couple of our transplant patients that have had babies after transplant through IVF and or donor eggs. So I think there are more options available for women and men now. We've got somebody else who has he's had a little baby through IVF, so it's his sperm that was stored 13 years ago, and his little boy is 5 or 6 now. So there are some really nice stories, but I think
it's about having those
discussions with your
obviously,
team to talk about the options.
Even if you sort of before with your intensive chemotherapies, hopefully that would have been discussed with your clinical team, and also they can support you after transplant in terms of your referrals back to specialist centres. They are difficult ones, and it's something that certainly for people of younger age, Sophie, who kind of you might not have even had to think about sort of when you're going to have children. Suddenly you're having to have all these conversations about your disease, about transplant, the fact that you might be infertile. So I think I think that's a really important subject that needs to be discussed with the patient, and at that time and doing it, and afterwards, because you might feel that you've almost had a bit of a loss, really, because if there is that loss of fertility, and it's coming to terms with all of those sort of issues which kind of arise afterwards. And sort of after transplant, again, there will be a point where in your sort of follow-up protocol, they will be looking at early menopause, and also probably referring you to specialists for that. So, endocrinology centres, and also, our fertility centres as well would work with us normally with patients who were going through their induction chemotherapies originally, and then post-transplant and things, they would then also take referrals for further advice. So I think it is just about getting those other specialist centres to support you in terms of giving you the correct advice and options. What are the options? And I think that's key, really. Again, as we go back to the same thing with transplant patients, it's so individual, and what we kind of love about our job is that patients surprise us.
We always come out with something. Olive going to clinic now.
Always surprise us with something, and we don't have a crystal ball. We don't have all the answers.
I definitely agree with all of that. I think that keep talking about it, and people wouldn't look at me as a 24-year-old and think that that's what's going on, but it is. So there's things they can do, and there's things that they can help you with. But no, that's amazing. Thank you both so much. We've covered so much in this talk. I've really enjoyed it.
Thank you.
No, it's okay. You've both been brilliant, and I think that I'm hopeful that we've done a good job of talking about the side effects and some of the ways that we can manage them. But we're gonna come to a little bit of a close now. I'm going to draw to a close. I've got a few slides to go through, but I just want to say a massive thank you to you both. You've both been brilliant, so thank you both so much.
Thank you, Sophie. Thanks for inviting us.
Brilliant. So here we go. Let's do our closing slides. So as you know, we've got a lot of services on offer at Leukaemia Care. So we've got our wonderful webinars, which you're watching right now, and also things like our newsletter, podcasts, and also we're very active on social media and updating our website. So if you want to see what we're up to, then please do have a look at there. We've got only 2 webinars left of the year. So the next one is next week, actually, and it's all about employment rights, and I will be there on the panel to talk about that as the advocacy officer. And then, quite appropriate, right before Christmas, loneliness and leukemia, because it is a bit of a lonely time for patients. So we're going to have a good chat on that one. Should be a good session. So those are the ones coming up. Check them out if you would like to come. And as Ruth and Lisa very kindly put on their slides, we have lots and lots of booklets, including 2 about the different types of transplant, and also, of course, our different types of leukemia as well. And you can order them for free on our website. Have a look. There's quite a few on there now. Yeah, we love our booklets. Support services, helpline and WhatsApp. I have the WhatsApp phone, so if you want to have a text or anything like that, then you'll get through to me. And if you phone the helpline, then it'll either be me or one of the amazing support team. And we also have loads of other things going on, like support groups and welfare and advocacy, which is myself and my amazing colleague Lisa. And also things like our forums. If you've ever got any questions and you want some of that peer support, check out there, and post anything on there, and everyone on there is amazing. So anytime you want some support, then just come through any of those channels and we'll be there. So support groups, I think there's only a few left for the end of the year, but I think planning is well underway for 2023. So any support groups where you can come together with a group of people with the same diagnosis or from the same area, then have a look on the website, or just reach out by email, and we can find out what group is most local for you or would be best for you. And of course, again, that peer support is so important. So the buddy scheme, an amazing service where we can connect you with someone who's trained to support you, and someone who was possibly been through the same treatment or same diagnosis, and ultimately just to have a chat to each other and to talk about how you're feeling, and maybe get some advice on what food that you want to eat after your transplant. Advocacy service, that is me. So I do a bit of everything. So if you've ever got any questions about employment, or even questions about transplant, because as you know, I am a patient myself, so again, just anything like that, come through to us. And we also know it's a worrying time of year in terms of finances as well, so our welfare officer is on hand to help with any advice about finances and grants and benefits and things like that. Counselling fund, we have our counselling fund where we can provide funding for up to 6 sessions of private counselling, because it's a lot to process when you're going through a transplant, so it's nice to know that that option's there for whenever you're ready, and if you want to get some support with that from a professional. And then, of course, we all have a bit of fundraising. So if you have any local shops around and you think that they might want one of our collection tins, then please do order one. We like to see them around everywhere. So it's always nice, a little thing that you can do. And something that we've been doing for Christmas is our little star wall. So you can light up a star for anyone who you like. It can be a family member, or it can be for yourself or a friend. And it's just a little nice way to do something nice, and to visualize a nice comment for someone who you care about. So we love that. And of course, patient stories, latest news, always on our website, and of course the social media, really active on there. So check it out if you want to see any updates from us. And of course the helpline and emailing for any questions. If anyone's got any questions after the webinar, please do send them over, and we will follow up with you as best as we can. That's brilliant. Right, thank you all so much for watching tonight. Hope everyone enjoyed it, and we will see you again hopefully on the next one. See you later.